Good morning, everybody, to this Wednesday morning. And I welcome you all on behalf of Insight and Abside, to our topic for this week. Before I begin, I'd like to start our proceedings today by acknowledging the traditional custodians and the owners throughout Australia, to also acknowledge their continuing connection to land, water, culture, community, and their knowledge and teaching passed down from generation to generation. This morning, we pay respects to elders past and present. So my name is James. I'm one of the educators here with Insight, and it's my pleasure to welcome along with us this morning our presenters, who are Dr. Jasmin Grigg and Peta Stragalinos, who come to us from southern parts of the country, but I'll let them talk to you about a little bit more about that in a few moments' time. So our topic this morning is Health4Her, really looking at this issue of how brief interventions can be used in a comprehensive way when working with women attending other services, in this case specifically breast screening services. Now, Jasmin, thank you. Hello, welcome. Come on.
Thanks, James.
That's great. And so Dr. Jasmin Grigg is a research fellow in addiction studies at the Eastern Health Clinical School Faculty of Medicine, Nursing, Health and Sciences of Monash University, and also works across Turning Point, a wonderful organisation down there in Victoria, who have reaches far beyond their state borders in terms of, I know I get a lot of value from their resources and their research on an ongoing basis. And we're also, Jasmin is joined by Peta Stragalinos, who is a research assistant and is in the clinical and social research team with Turning Point as well. So welcome to you as well, Peta, and see you there. Great.
Hi, thanks for having us.
So I'll hand over to Jasmin and Peta in a few moments' time, but just to let everybody know who's joined us, that for any questions, queries or comments today, you're very welcome to pop those into the chat. They will come to the hosts and the panelists, so we'll be able to view those. Our plan is to spend the last sort of 15 minutes or so of the 1 hour that we have together today to put as many of those questions to Jasmin and Peta as you're able to send through. So send those through at any time. But without any further ado, I'll hand over to you both. And thank you very much again for taking your time to spend with us this morning.
Thanks very much, James, for the introduction. Appreciate it. And many thanks to the Insight team for inviting us to present a body of research today that we've been working on since 2019 to understand whether a novel, tailored alcohol brief intervention is needed in the breast screening setting, whether it's acceptable to women who attend these services, and whether it works to improve women's alcohol literacy and address risky consumption. I'd like to begin today by acknowledging the Wurundjeri people, the traditional custodians of the land on which we are presenting from today here in Melbourne, and acknowledge the traditional custodians of the land from wherever you may be joining us online. I pay my respects to their elders, past and present, and I extend my respect to their Aboriginal and Torres Strait Islander peoples here today. This presentation provides us with the opportunity to highlight one of the most critical health issues impacting women around the world, and also their families, friends, and caregivers. We hope that this research will contribute to ongoing breast cancer prevention efforts and play a part in increasing public awareness of the role alcohol plays in the development of breast cancer. And I also want to kick off by acknowledging the broader team that's behind this project for their expertise and contributions over the past few years. It's been a great team to work with. I'd also like to acknowledge our funding partners, Vic Health, the Eastern Health Foundation and Shades of Pink, and our collaborating organisations, Monash University, Turning Point, Eastern Health, Breast Screen Victoria, and the Life Pool Project. So for a bit of background, first up, here's what we know. Breast cancer is the most prevalent cancer in Australia and globally. There are more than 2 million new cases diagnosed and 685,000 deaths worldwide each year. And in Australia, there were over 20,000 new cases diagnosed in 2022, and there were more than 3,000 deaths. A woman's risk of developing breast cancer is due to a combination of non-modifiable and modifiable factors. While there's some risk factors we can't change, like family history and getting older, other factors can be modified to decrease risk. And there's now strong scientific evidence that alcohol is a major modifiable risk factor for breast cancer in women, with 4.5% of cases worldwide attributable to alcohol consumption. This proportion is even higher in Australia. 6.6% of cases among postmenopausal women and 12.6% of cases among premenopausal women are attributable to drinking alcohol. And further, alcohol consumption is associated with 10% of all breast cancer deaths, with this number as high as 18 to 20% in regions with higher alcohol intake, including Australia and Western Europe. So let's take a moment to consider how much alcohol is in a standard drink. Here in Australia, a standard drink refers to 10 grams of alcohol, which for example is about 100 mils of red wine. But it's important to know that a serve of alcohol that you pour yourself at home or get at a bar or restaurant usually contains more than one standard drink. For example, the average restaurant pour of red wine contains 1.6 standard drinks. There's a dose-response relationship between alcohol and breast cancer in that the more alcohol consumed, the greater the risk. And we now know that increased breast cancer incidence is associated with lower consumption levels than those previously deemed safe, as little as 0.6 standard drinks per day. Breast cancer is now recognised to be one of 7 cancers causally linked to alcohol consumption, even at very low levels, along with mouth, throat, esophageal, liver, and colorectal cancers. Also, among women who've been treated for breast cancer, drinking low amounts of alcohol can increase the risk of recurrence. However, population awareness of the alcohol breast cancer link has remained surprisingly low, including among mid to older aged women who are a population at highest lifetime risk for developing this cancer. And while Australia's use of alcohol is declining, the prevalence of risky drinking has increased significantly among mid to older aged women. This is consistent with research from other Western countries that has identified steady increases in mid to older aged women's drinking, likely due to the social, cultural, economic changes, including women's participation in education and the workforce, greater financial independence, and increasing acceptability of female drinking, but also due to prolific and deceptive marketing by the alcohol industry, including the exploitation of breast cancer awareness campaigning to sell more products and ultimately contribute to risk in the name of prevention. For example, One Hope Wine's Pink Glitter Edition Chardonnay helps fund breast cancer clinical trials. Pop icon, breast cancer survivor and awareness campaigner Kylie Minogue has a range of wines with distributor Benchmark Drinks, selling 800 million bottles since 2020. And South Australia's Jim Barry Wines raises funds for the McGrath Foundation, a breast cancer support and education charity. But although alcohol consumption among mid to older aged women continues to increase, this issue remains largely overlooked, and health information about the alcohol breast cancer link is not systematically provided. For example, a recent study looking at the experiences of women attending breast cancer screening and treatment settings in the UK. In this study, women commonly reported that not once did the subject of alcohol come up. So given all of this, we started to wonder how we could go about implementing an alcohol brief intervention in the breast screening setting. Alcohol brief interventions are short sessions where a few brief questions are asked about a person's alcohol consumption, followed by the provision of information and strategies to keep drinking in a low risk range. While there's meta-analytic evidence for their effectiveness in improving alcohol literacy and reducing consumption when delivered in general practice GP settings, there have been multiple barriers to their implementation, such as limited GP time. And as a result, there have been a call for other health profession involvement in responding to harmful alcohol consumption in the population. Population-based breast screening programs are uniquely positioned to provide timely, targeted alcohol brief interventions. The screening appointment can act as a window of opportunity to increase engagement with breast cancer risk reduction information. And with 43 million women participating in screening each year in Australia, the US, and the UK alone, this setting has potential for extensive reach. So we set out to understand whether alcohol brief interventions implemented in this novel setting are needed, whether they're acceptable to women, and whether they work. And for the first two studies that I'm about to present today, we used applicable elements of the consolidated framework for implementation research to guide the identification of factors that can promote successful program implementation, with these studies mostly focusing on the outer setting to identify need for alcohol brief intervention among this population, intervention characteristics, particularly adaptable elements to improve implementation, as well as some features of the inner setting and implementation process. For the first study, we wanted to confirm whether the approach we were proposing was even needed in the first place. Our aim was to examine the prevalence of risky drinking among breast screening service consumers, according to the latest Australian alcohol guidelines. This was a retrospective analysis of cross-sectional data from Peter McCallum Cancer Centre's Life Pool project, where we analysed the alcohol consumption data of more than 49,000 women who were recruited mostly through the statewide breast screen program, Victoria's program, who were aged 40 years or more, living in Victoria, and had completed a Life Pool entry questionnaire. The Life Pool entry questionnaire contains a series of demographic and health-related questions, and our study's been the first to examine the alcohol data of this large sample of women, which included quantity, frequency, and frequency of heavy drinking days variables. So let's take a moment to consider the latest national recommendations to reduce alcohol-related health risks. In response to recent evidence for the harms associated with drinking alcohol, recommended consumption limits have been decreasing in Australia and also in other parts of the world. In December 2020, the Australian National Health and Medical Research Council decreased the recommended limit for healthy adults from 2 standard drinks per day, which was effectively 14 standard drinks per week, to 10 standard drinks per week, and advised consumption of no more than 4 standard drinks on any one day. Of women in our study, who were on average 60 years of age, results showed the majority had recently consumed alcohol. 1 in 5 were drinking at a level exceeding current national guidelines for weekly consumption, and 1 in 6 were exceeding guidelines for consumption on a single day more than once per month. We also found similar proportions of women with a history of breast cancer exceeding weekly and single-day guidelines from this sample. So while the cross-sectional nature of the data prevents the temporal ordering of diagnosis and drinking level, these results are consistent with previous Australian research that shows some women continue to drink at risky levels or even increase their consumption after a breast cancer diagnosis. So overall, while women attending breast screening might typically be considered a more health-conscious group, this study found risky drinking to be highly prevalent among this large sample, according to the latest national guidelines. The findings make a strong argument that there is a need to address risky alcohol consumption among this population of women, and are concerning in light of the strong evidence that drinking even very low amounts increases breast cancer risk. Indeed, the new Canadian guidelines mark a substantial shift in operationalising risky drinking, recommending consumption of no more than 2 standard drinks per week to lower risk of alcohol-related harm, and this equates to about 2.5 standard drinks using Australian measurements. And with 7 standard drinks weekly considered increasingly high risk, which is the equivalent of 9.5 Australian standard drinks, and which is within our current recommended limits. So in the second phase of the research, we wanted to understand whether it's acceptable to offer information about alcohol to women attending breast screening. And we also wanted to understand how to implement an alcohol brief intervention in this setting in a discreet and non-stigmatizing way. This was always really front of mind in all of this research that we were doing. In 2020, we conducted a mixed methods study involving an online survey with 391 women who were breast screening service consumers. and we worked with an additional 31 women to collaboratively design the alcohol brief intervention to be tested in the following phase of the research. This time, members of the Life Pool project were invited by an email circulated to randomly sampled groups of women to participate in a survey, focus group, or telephone interview. So we found that of the women surveyed, 9 out of 10 reported recent alcohol consumption, which was slightly higher than in the previous study, and a higher proportion, 1 in 4, were drinking above current national guidelines for weekly consumption, which, as we learned before, now recommend that healthy adults drink no more than 10 standard drinks per week. We also found that just 1 in 5 women accurately identified alcohol as a risk factor for breast cancer. In contrast, pretty much all of the women surveyed identified family history as a risk factor, which shows a big discrepancy in this group's knowledge of evidence-based breast cancer risks. Women want to know, and they want BreastScreen to tell them. An impressive 97% of women surveyed supported adding a few minutes to their screening appointment in order to receive breast cancer risk reduction information, which wasn't seen to be intrusive, but instead to be a positive addition to the current service provided. Also, 95% of women considered breast cancer risk reduction information provided in this setting to be more credible than from other health professional sources, and that included GPs. Women participating in focus groups also supported the idea of receiving alcohol information while attending screening. For example, Linda said, "You're not just there to have a check, you're there to be educated at some level as well." And Jane said, "BreastScreen are the experts, that's why we go there." Through the focus groups and telephone interviews, women offered several ideas for the design of the alcohol brief intervention. They strongly endorsed the use of visual information, particularly video with audio. They said that they were stressed when they're attending these appointments sometimes, anxious about the outcome, and the last thing they want to do is read a lot of text. So we took this on board and worked with an animator to develop the intervention, some parts of which you can see here. They suggested providing the alcohol information alongside general lifestyle information to make the intervention relevant to all women, and so that women who drink didn't feel singled out. To achieve this, as you can see on the left, we included information on physical activity and keeping weight in a healthy range as other ways to reduce breast cancer risk. Women agreed with us that the messaging of the intervention shouldn't be one of abstinence, but to be consistent with and increase women's awareness of the drinking limit recommended by current national guidelines, along with messaging such as the less you drink, the lower your risk of alcohol-related harm. However, women also endorsed the use of impactful messaging about alcohol risks, rather than sugarcoating it, as one lady said, and also for alcohol behaviour change to be framed as a choice for women to make. So with these points in mind, and also to keep the alcohol brief intervention relevant to all women, we developed 2 versions corresponding to drinking levels that exceed and do not exceed national guidelines. For women drinking more than 10 standard drinks a week, we developed personalised messaging, as you can see in the top middle tile, informing them that they are drinking above the recommended limit, that 8 out of 10 women their age are drinking less alcohol, and that the amount they are drinking is putting their health at risk. And for women drinking 0 to 10 drinks per week, we developed alternative messaging, informing them that they are drinking within the recommended amount, that they're doing a good thing for their health, and the less they choose to drink, the lower their risk of alcohol-related harm. As well as this personalised feedback based on drinking level, both versions of the alcohol brief intervention contain negatively framed messaging around alcohol-related risks and harms, positive frame messaging on the health benefits of reducing alcohol intake, and harm reduction strategies. So to sum up, Study 2 showed that offering breast cancer risk reduction information in the breast screening setting was perceived by women to be highly acceptable. This phase of the research also led to the development of the alcohol brief intervention, which we called Health4Her, with input from women to ensure its appropriateness for the screening setting. So now my colleague Peta is going to present our most recent phase of the research, where we sought to understand whether an alcohol brief intervention implemented in the breast screening setting works. Thank you for your time.
Hi, thanks, Jasmin. So as Jasmin said, I'll be presenting on our findings from study 3. In this final phase of the study, we sought to understand whether an alcohol brief intervention implemented in the breast screen setting works. So to do this, we conducted a hybrid effectiveness implementation trial in 2021. The aims of this world first trial were firstly to determine whether the Health4Her intervention improves knowledge of alcohol as a breast cancer risk factor. Secondly, whether it improves alcohol literacy. And thirdly, whether it reduced alcohol consumption. We also sought feedback about the intervention and its implementation from the women who participated in the study and the Maroondah breast screen staff. The study design was a double-blind, randomized controlled trial, which was chosen because it allowed for rigorous comparison of Health4Her against a control group. Program evaluation of the intervention was guided by applicable elements of the RE-AIM and CFIR frameworks. Trial participants were 558 women who attended routine screening at Maroondah Breast Screen in Melbourne, Australia, and women were randomly allocated during their baseline assessment to receive either the Health4Her intervention, which included the alcohol brief intervention and lifestyle information, or to control, which only received the lifestyle information. And just to provide a bit of context as to how Health4Her was implemented at Maroondah Breast Screen, women attending the service were invited to take part in our study after their screening appointment. Women who agreed to participate were then asked a few questions about their knowledge of breast cancer risk factors, their alcohol consumption, and other general lifestyle questions, such as their level of physical activity. Women were then provided with an iPad and headphones to view the animation, and they also received take-home pamphlets with a summary of the information which corresponded to the intervention that they received. There were 2 follow-up assessments conducted by a different researcher, which occurred 4 and 12 weeks later. Of the 558 women who participated in the study, 279 were randomized to the Health4Her intervention and 279 to control. On average, participants were about 60 years of age. 82% had recently consumed alcohol, which was actually slightly lower than what we found in our previous 2 studies. And just 1 in 5 had knowledge that alcohol consumption increased breast cancer risk, which is a similar rate to what we found in our previous survey. The proportion of participants completing their follow-up assessments over the phone was high. We had 93% of participants complete their 4-week assessments and 89% complete their 12-week assessment. We also conducted 30 semi-structured qualitative interviews with a subset of women who were allocated to the Health4Her intervention after they completed their final assessment. So for the primary outcome, we found that change over time in the proportion of participants accurately identifying alcohol as a clear risk factor for breast cancer was significantly greater in the intervention arm, represented here by the red bars, relative to control. This finding was echoed in feedback from participants who had been allocated to the Health4Her intervention. For example, Cindy said, "I was surprised that alcohol was raised as a cause for breast cancer because I had assumed it was primarily due to genetic factors." While Laurel said, "I didn't even realize there was any link. You don't think it's something that happens because you might drink a bit too much." We also found positive results for other alcohol literacy outcomes. Change in the proportion of participants accurately identifying, firstly, the amount of alcohol in an Australian standard drink. Secondly, the number of standard drinks in an average serve of red wine. And thirdly, the maximum weekly consumption recommended by the Australian National Guidelines was significantly greater in the intervention arm, again represented here by the red bars. Although, while we did see significant changes on these outcomes, we can see here that overall alcohol literacy remained low, with fewer than a quarter of participants allocated to the intervention responding correctly to these items, indicating that there is still a lot more work to be done. These findings were supported by participant feedback. For example, Nellie said, "It's like, oh shit, okay, I'm actually having 6 drinks on an evening, not what I thought was my maximum of 4. And Cordelia said, "Hearing about the actual serving sizes made me more aware of how much I was drinking." Meanwhile, Leonie asked, "Why is a fluid measured in grams? How could I know what 10 grams of alcohol is?" This feedback from Leonie is not unique to our study sample, but it does reflect continued widespread confusion in the community regarding the ethanol content of drinks, which has implications for effective public health messaging about alcohol. For alcohol consumption outcomes, while changes over time were not significantly different between groups, some participants reported that they had reduced their drinking as a direct result of the intervention. For example, Helena said, "I moved from 3 alcohol-free days to 5 consecutive alcohol-free days. I felt good about that." And Lauren said, "You know, maybe on a weekend, if I'd have 5 scotches, I now might have 3. We also found that the proportion of participants accurately identifying physical activity and keeping weight in a healthy range as other ways to reduce breast cancer risk significantly increased for both intervention and control arms, who both received this general lifestyle information. As Darcy described, "So I've tried reducing alcohol and I've been exercising more." And Alma said, "I was sort of thinking, do we really eat our fruit and veggies? And now I make sure that we do." These findings demonstrate the added benefits of the Health4Her model in providing information about other modifiable breast cancer risk factors. And it provides support for the implementation and relevance for all women who are attending breast screening services, including for those who don't drink. We also found that a significantly higher proportion of participants in the intervention arm reported that they had shared the health information they had learned with others. So for example, Teresa said, "I remember telling my sister that I'd just seen this video about the impacts of alcohol and breast cancer. She hadn't known that." And Eloise described sharing the alcohol information with a friend. "I mentioned the fact that Health4Her had given me interesting information about alcohol, and it did spur a chat about it." Meanwhile, Adeline said that she had brought up the Health4Her intervention when chatting with a group of friends, and she said, "So yeah, we had a bit of a laugh, but actually a whole lot of us did make a conscious change." This indicates that our messaging had reached beyond the participants of the trial, and it also suggests that the alcohol information was particularly interesting for women to learn about, and that possibly the intervention contributed to distributed alcohol literacy, where health knowledge is shared beyond the intended target and can influence social practices within the individual's social network. We also sought participant feedback about the health information being received in this setting. Some participants did report that the information about alcohol had made them feel uncomfortable, but this was mainly because it made them reflect on their own drinking habits. So, for example, Helena said, "I know that my alcohol consumption is too high, so it was a bit of a kick up the backside, really." And Alma said, "You answer these questions and then actually you're drinking over the limit. And then you realize they're not talking generally, they're talking specifically. So yeah, it was quite effective, but confronting." Still, an overwhelming 99% of our trial participants reported that the health information they received was acceptable, and 96% endorsed that it should be part of the standard service provided by BreastScreen. 97% of participants reported that the health information was trustworthy. The setting seemed to be an important factor that contributed to how the information was perceived. Receiving information about breast cancer risks within the setting also appeared to carry more weight than if it had been received elsewhere. As Marina described, Breastscreen is a reputable organisation. The fact that it was in that setting certainly made it more credible. And Bethany said, if it wasn't backed by proper research, I don't think it would have been allowed to be delivered in that setting. "98% of trial participants reported that the provision of health information via an iPad was acceptable. And 94% reported that they would be comfortable receiving an iPad and headphones to participate in a waiting room if the intervention was implemented in practice. And while some women did raise concerns that the iPad modality could be a barrier to participation, to our knowledge, we didn't have any women decline to take part for this reason. Our intention was to make the intervention as simple as possible, and this appeared to make it easy for women to participate, even if they were unfamiliar with this technology. As Darcy described, a lot of the women that come for breast screening are older, and therefore we're not up with the technology. But once I was told what to do, it wasn't too hard at all. Importantly, 86% of women reported that receiving Health4Her had made no difference to their likelihood of attending future screening appointments, and the remaining 14% reported that receiving the information had made them more likely to attend future appointments. A limitation of this research is the possibility of social desirability bias, where social desirable attitudes and feedback about the intervention may have been overreported. However, program feedback was collected via telephone interviews, which are more robust to the effects of social desirability, as they permit a greater sense of privacy and anonymity. As part of program evaluation, we also interviewed the breast screen staff about implementation of the intervention. Staff were highly supportive of Health4Her, of the Health4Her intervention as part of their routine care, and they were excited to play a role in breast cancer prevention. For example, one manager said, "We have these women coming in who are interested in doing the right thing for their health, yet we give them no information about what they can actually do to improve their health." Another manager said, "Health4Her is taking a client-focused approach. This is a kind of health information that women need to know, they want to know, and it's something that they can do something about." However, staff indicated that there may be some challenges with implementation at other screening sites, and they reinforced the need for a self-completed version of the intervention that does not require researcher or staff facilitation. Staff even suggested allowing women to participate in Health4Her on their own device after their appointment as a way to overcome this barrier. For example, one radiographer with experience working at other breast screen sites described that some screening sites don't have space for a researcher to see ladies after their appointment. You're going to have issues with some of the sites. And another radiographer said that if it was offered at other screening sites, that would need to get the module right. So there's minimal need for staff support and minimal disruption to workflow. Informing women that there would be an additional thing to do ahead of their appointment was seen by staff to be an important factor that facilitated implementation. To improve recruitment during the trial, we worked with the breast screen service to introduce a text message, which reminded women about their upcoming appointment and also mentioned the Health4Her study. Staff reported that this had a positive effect on both participation and workflow. So, for example, one of the receptionists explained, "There was definitely a great improvement once the text reminder went out, a massive improvement. I think that helped participation greatly." And a manager said, "The text messages sealed the deal for the staff because it made it a whole lot easier for them because clients were already aware of Health4Her when they came in for their appointment." Finally, breast screening staff suggested that developing the intervention to require little facilitation from staff, and if it could provide evidence that it worked, that it could be a significant facilitator for widespread implementation. As one of the radiographers described, "If we can show that the intervention works and it's an easy package or module, Victoria and the other states and territories, I think, would be on board." So to sum up study 3, the Health4Her intervention implemented in the breast screen setting improved women's knowledge of alcohol as a breast cancer risk factor, improved alcohol literacy more broadly, and it was acceptable to women. And while breast screening staff were highly supportive of the Health4Her as part of routine care, some potential challenges with implementation were identified, in particular the current requirement of research or staff facilitation. While further research is needed to examine the effectiveness of this type of intervention in reducing women's alcohol consumption, this study represents an initial step towards increasing alcohol literacy and reducing harmful consumption among this under-recognised and high-risk population of women. So, where do we go from here? We've recently received support from the Shades of Pink fundraisers to co-design and trial an automated version of Health4Her with breast screening consumers. Automation of this intervention, meaning that it could be fully self-complete on your device like an iPad, provides a low-cost, labour and time-efficient approach that has the potential to overcome some of the issues with implementation in busy healthcare environments. For this next iteration of Health4Her, we're collaborating with Monash University's Action Lab to develop the automated intervention. An important objective of this next phase would be to ensure that the automated intervention is straightforward and easy for women to engage with. We're also taking into consideration the barriers to participation and the feedback we received from our previous studies, and evaluating whether there's a need to offer the intervention outside the breast screen setting, such as sending it to them after the screening appointment, or offering it to them when they book their appointment, which would allow them to self-complete the intervention in their own time at home or where they may be. Exploring these different modalities will allow us to maximise the reach for all women to attend breast screening services. We then plan to test the automated Health4Her intervention in a powered multi-site trial for its effectiveness in reducing women's alcohol consumption. This study will be completed alongside a comprehensive program evaluation to understand factors that may affect future implementation. So, to conclude, we found that the alcohol brief intervention in breast screen settings are needed, they're acceptable to women, and we've provided preliminary evidence for their benefits. Expanding access to alcohol brief interventions in novel clinical settings, with an emphasis on reaching previously under-recognised high-risk populations, has the potential for substantial benefit. Finally, breast screening services are of particular relevance as a setting for this type of information, considering the increasing prevalence of mid to older age women's drinking, and the strong evidence that even very low levels of alcohol consumption can increase breast cancer risk. And that's all from us today. Thank you.
Gosh, thank you very much. Peter, I hope you're okay there. Please take a moment to have a drink of water, and Jasmin, we'll get you to pop back in. Look, thank you very, very much. And I just, just a few observations from myself before we get to some of the material that's come through from people who've joined us in the webinar today. This is probably one of the most thorough pieces of research I've seen, and I know there's been other ones, but just in terms of how you've gone about this to determine, quantifiably that it's needed, and then going through, would it be something that would be received? So we know that screening and brief intervention is something that, and having those conversations that count is such an important thing, but to actually to take that wonderful step there to kind of work out, well, is this the right place for it? Would it be received? To try and set up and maximize things for, messages and outcomes being the best as possible. Awesome. And then you've actually gone through and you're doing the work around did it work in terms of that pilot. Really, really comprehensive, both for you and the team, that large group of people that you showed all their wonderful faces before. So just my acknowledgement of that. And I have a few kind of thoughts and reflections, but I'll just go to some of the things that popped up in the chat, which Jasmin and Peter, you may have already seen there, but we have somebody who's very kindly shared, and I probably didn't acknowledge this or recognize this at the beginning, but I imagine that there's lived and living experience of this topic in our audience today, and just really want to thank the generous sharing for some of the comments that have come through where people are coming from that perspective. And so we have a comment here for somebody who's at a consumer advisory panel member on the Breast Cancer Network of Australia. I'm not sure if you're both familiar with that body or that group, who is, just kind of pointing out that they weren't ever asked about alcohol when they were going through a process and then also receiving a diagnosis of breast cancer, and have since then been wanting to really kind of advocate for the matter of alcohol being something that is raised or that does have kind of some type of place within the process where women are coming in contact with the health system. And I'm just wondering, and from this comment there's a request around, is it okay to share this information? And I gather you've got the studies that you could possibly, and your contacts are up there. So to Kath, who's posed these questions, please take note of these. Would that be okay, Jasmin and Peter, for Kath to maybe get copies of the research and things?
Oh, absolutely. I'm only too pleased, Kath, if you'd like to get in touch with me, and I can share with you the peer-reviewed papers and anything else you might like slides, etc.
Yeah, that's really good. And I'm just wondering, is that common that you've in all your work with setting this up and proceeding and doing the research, that people have been surprised, or it hasn't been something that's been on the radar?
Yeah, so in international research and our own trial and pre-implementation work echoed what's known internationally, that about 1 in 5 women in this kind of age range are aware of the alcohol breast cancer link. So 20%, it's not much, and it needs to improve. Just so women can make sort of informed decisions about their alcohol. We never wanted to promote like the idea of abstention, of miserable abstention. That's not what we're about, but just like letting women know what the guidelines say and how to help keep their drinking in a low risk range is the ultimate aim of this project.
Yeah, absolutely, which combines all of those really important things that we know from the motivational literature, where brief interventions really kind of grew out from, is around that stuff about choice, autonomy. If you start making messages or that take that away or are kind of aimed at sort of the fear, then you often get the pushback. So you've done that really, really well. And I'm just noting as well that the credibility factor that's a really interesting one. And I know that because of, and I'm thinking of the parallels here to the area, it's different, but the parallels to the area with fetal alcohol spectrum disorder and the campaigns that went out a few years back around what women want to know, that was based on this evidence that really showed that women want to be asked, they want to know, or it's an issue if they're not. So you found that breast screening services were considered to be really credible to provide this information?
Women have a really positive perception of breast screening services. They see them to be very efficient, reliable, sensitive. There's really overall positive perception of these services that they visit. And yeah, as you saw in some of the quotes that we presented today, they're just like, they're the experts. That's why we go there, and we're very receptive to receiving this alcohol information in that setting.
Yeah, well, shout out to anyone from Breast Screen Australia who's listening in today. And got a question here as well. Interested to know your thoughts on why there is a great gap in knowledge and education around the risks of alcohol and breast cancer.
It's not something that's like, I wasn't even aware until we started doing this project and looking into the research. I was just like, not even, you know, the link, but just how little you need to drink to possibly increase your risk of breast cancer was something that just really surprised me as I embarked on this research. The information's not out there. I feel like health professionals perhaps leave it alone because, you know, particularly if someone is being diagnosed with a harm that may have be associated with alcohol consumption, you know, they don't want to be kind of inciting judgment and blame at a time where a person is receiving a diagnosis. And I guess Breast Screen Victoria anyway have traditionally, you know, they're focused on service provision, not health promotion. So this has been quite a new thing for us to do in collaboration with Breast Screen Victoria.
Yeah, absolutely. And just where you were talking there about that kind of health promotion or primary care, and I know that there's the plan to roll this out into sort of a wider multi-site trial. There's a question come up here about, are you aware of any opportunities, or is there any opportunities that this information is provided to, I guess, a wider audience of GPs? I mean, that may not be something that your role is as the researchers building the evidence base, but just interested to know if you've had any interest from other areas outside of breast screening.
We have had some interest from Scandinavia, sort of breast screening services over there, where we collaborate with Breast Screen Victoria. But in terms of kind of spreading this message of you know, amplifying this message, we want to build upon the research. We want to sort of see the effects in reducing actual alcohol consumption. So the multi-site trial will be the next step after automating the intervention. But then we you know, you think about kind of smoking cessation and how it took like 3 decades of campaigning in different ways and different, you know, sort of, you know, different advertising, different programs. And I feel like, you know, sort of reducing risk from alcohol will require the same multi-pronged approach over several years. And yeah, we'd love to be part of that, but also, you know, sort of build that, particularly as far as alcohol and breast cancer risk is concerned.
I'll also add that the animation style that we chose, like, it's one of the benefits is that it can be changed, and we can include additional information that could make it relevant to, you know, if it was often in different settings. So it does kind of allow for adaptability in that way, which was one of the benefits of using animation.
Yeah, absolutely. Great. Absolutely. And, you know, you're both doing your part in that process of getting information and the evidence out there, and often probably there's other forces that we're often working with in these things as well. When you gave that example of like the tobacco kind of narrative and where that's come from. I'm interested to know the secondary outcomes finding that you had around that women are obviously just sharing this information with others. Was that a surprise, or was that something that you kind of predicted, or did it come out through the kind of the evolution of looking at the data?
No, that was an exploratory outcome. So we really didn't know how that would go. You know, it could have very much been the case that the control group that received just the general lifestyle information could have just, you know, sort of shared that information as well. But what we found was women receiving the alcohol information was significantly more likely to share that information with others. So as Peta said, you know, they seemed to be more interested in the alcohol information than the general lifestyle stuff we gave them. So it was exploratory, and we were impressed to see how far the message was being spread.
Sure, and it's nice that you packaged up the initial screening and the education around a range of modifiable risk factors, not just the alcohol, obviously to help make this, you know, kind of less stigmatizing, less kind of all those sort of things. And some of those numbers that you got in terms of the 90% and the acceptability and all those sort of things are just amazing kind of results, and so timely, because when I know the data for the current National Drug Strategy Household Survey is, you know, not due till later this year, but I know on the last reports, you're looking at those increasing since 2001. People 70 years and older have been the largest group represented in daily drinkers.
Yeah.
And people in their 40s and 50s are often the ones who are most likely to be drinking beyond lifetime risk kind of, guidelines and levels. So all of those factors very much coming together. So very, very timely and just so practical. And,
we hope so. We're continuing to work on it. The next goal is one of the sort of tasks in automating it is also to reduce the size of the animation. I think it was about 7 minutes initially, whereas we're just really trying to cut that down as well. So it's a work in progress, James.
Yeah, no, that sounds like our life here as well. Everything's got to be down to chunks and bytes and things like that. I think things like YouTube, Instagram, and TikTok have conditioned us for that, but still a very powerful way to get the messages across, to use the audio and the visual, as you said. So which is really good. And you answered all my questions that I was saying to have around the level of comfortableness with technology, given that you often are working with that kind of older demographic. Probably my only other kind of just question, and it wasn't necessarily about this study, but with breast screening, I know that there's a large coverage of that across the population, but there are vulnerable groups that do miss out on that. And those vulnerable groups generally would potentially have higher risk factors around things like alcohol use and patterns of alcohol use. So in the multi-site trial, is there any kind of consideration around, say, demographic, social demographic areas and those sorts of things? Yeah.
Absolutely. So we've been measuring, sort of health inequity groups. We've got that. We're tracking that. We've been tracking health inequity group membership the whole way through this study. But ideally, for the multi-site trial, it would be great to sort of get a sort of representation from, of course, city sites, but also regional, remote sites as well. And there's also Victoria, BSV has 2 buses as well. So to be able to implement the intervention, the study on one of the buses or both would be a goal of ours as well.
Well, more power to you for that. I hope it does come out, because that will also add a lot more power to the results and the generalizability of them as well. So that's awesome. Now, I'm just going to leave a moment here for anyone that wants to pop any other comments. Hopefully you're seeing both Peter and Jasmin, you're seeing the comments coming through about lots of thanks around this being an incredibly important area and something that, look, I have to say, probably for a lot, for some obvious reasons and others that, this isn't anything I knew about. So thank you for helping me increase my understanding around this as well. And that stat that you gave, or that from the research, that 0.6 standard drinks a day increases the risk factor for somebody who's previously had a diagnosis of breast cancer. That's I don't think that's out there very much anywhere.
No, you're right, and that's what we're trying to achieve.
Yeah, definitely. Yeah. Well, look, go well with that. Some more comments coming through about the thanks. It's some very passionate people have joined us today. So thank you to all of you who have joined us as participants today. And as we've made comment in there, you can come back at any time to our website to, if you would like to share this link to this recording, that will be up in the next couple of days. We find that we often get much larger attendance or much larger audiences through the viewing of these things through our recording library. So feel free to pass this on to anyone, as well as the presentations being made available. And Jasmin and Peter have kindly shared their contact details previously for anybody who wishes to get a hold of them. Thank you for being generous around doing that. And thank you also for the time, sharing your research, very incredibly thorough, well thought through, well constructed and well delivered, and for sharing those results today. We really, really appreciate that. For any of our listeners there who are available next Wednesday at 10 o'clock, just to let you know that our webinar will feature Dr. Catherine Turner, psychiatrist, who's the Executive Director for the Metro North Mental Health Service. And look, Catherine is generously as well talking about, from her background, her experience, and her current kind of focus on improving the management of suicidality and self-harm within our services and systems. So she's presenting on the paradox of prevention, paradigm shifts in the management of suicide and self-harm. And I would have to say, probably one of the most knowledgeable and passionate speakers on this topic that I've ever come across in my time in this work. So I hope many of you can join us next week or catch it on the in the recording library if you don't get to come along, similar to the presentation from Jasmin and Peta today. Thank you very much. Thank you all for your time, for coming along. Take care. And yes, we look forward to seeing you all back at another time. Again, Jasmin, Dr. Jasmin Grigg, Peta, Stragalinos, thank you for coming along with us today.